Is that our kid?
Hello.
All right, well, welcome. We are so happy to have you all here for our third annual birthday party. And for those of you who weren't able to make it live today, but made plans to tune in to the recording, hello to everybody in the future as well. Today, as we have each year, we're looking back on the past year of Family Planning Elevated, from our new partnerships to trainings to policy changes and brand new activities. And while we will start with our highlight reel focused on the year 2021, we are simultaneously celebrating the past 3 years of this initiative, because what you might not know about Family Planning Elevated is that this is one very precocious 3-year-old who will soon be graduating from service or retiring, depending on how you look at it. And we'll take a peek at what's next for this whippersnapper. On one hand, Family Planning Elevated has been about contraception, and we've used this term fairly interchangeably with family planning over the past 3 years. But as we take the next hour to reflect on the past few years, it's actually, in my mind, the creation of families that really stands out. The professional families we've gotten to know at partner clinics throughout the state, the growth of our own Family Planning Elevated staff family here at the university, back from a small, scrappy crew of just a few of us in 2019 to really a panoply of experts here. And for me, quite personally, FP has also bookended the creation of my family. My first kid was born the first week of FPE cap, and I'm expecting my second any day now during the final days of FPE cap. And of course, we're really delighted to consider all of you family as well. And we thank you for being part of this big, beautiful initiative with us. So sit back, relax, and enjoy the party. All right, so we'll start off by taking a look back at the biggest moments of 2021, our third year of FPE cap implementation. Great. All right, so let me take you back to early 2021. Training was on our minds. We kicked off the year really eager to host another big contraceptive education and training conference for providers and clinic staff, just like we'd done in the first year of the project. But even amidst that optimism driven by COVID vaccines early last year, we knew our approach to training in 2021 would have to look a little different from that of 2019. For one, we now had skilled providers at our clinics taking on more complex cases and sharing their skills with other providers. And so in May of 2021, we convened an advanced level training to increase the skills of a small group of champion clinicians at FPE cap clinics. We had 6 family planning specialists come to Salt Lake City for a full day of hands-on training and simulation on complex IUD and implant skills, barrier methods, and peer coaching. And then later in the year, 2 of those specialists assisted our regional trainings by providing one-on-one instruction to learners on barrier methods and IUD placement. And one of those specialists was able to introduce herself as a regional resource, extending the offer to shadow and proctor for nearby clinicians at her clinic for interested trainees. All right, next.
The end of 2020 proved to be difficult in terms of running digital media ads. Social media platforms tightened restrictions on ad placements, and FPE ads were actually deemed a social issue by Facebook and replaced in the same restricted category as political discourse. Therefore, we adjusted our approach to advertising, utilizing more traditional forms of media such as print and radio. And fortunately, in 2021, that year brought loosened restrictions, and we were able to successfully run digital ads on social media platforms encouraging Utahns to enroll in Medicaid, advertising no-cost contraceptive services available at our partnered clinics, and promoting educational content on a range of fertility and family planning topics. Each FPE CAP organization received a tailored media campaign with targeted images and messaging in both English and Spanish, and we're very excited to continue posting educational and awareness-raising content beyond the conclusion of FPE.
Having canceled our annual contraceptive education and training conference in 2020 due to the pandemic, we were eager to resume in-person trainings in 2021 to meet the needs of providers throughout the state to improve their knowledge and skills in contraception. To do this safely, we held 3 small regional trainings in Ogden, St. George, and Moab in partnership with Beyond the Pill, a national contraceptive training organization housed at the University of California, San Francisco. Increasing COVID-19 infection rates required us to convert the August 6th Ogden training into a virtual training, which was still attended by 25 individuals. Participants were able to schedule individual and small group training on IUD and implant separately. In-person trainings were held in St. George in October with 18 participants and in Moab in November with 22 participants. In 2021, the Division of Family Planning at the University of Utah published findings from a randomized non-inferiority trial, which demonstrated the effectiveness of 52 mg LNG IUDs as a new form of emergency contraception. Then we partnered with healthcare clinics in Utah to support them in translating the new evidence into standard clinical practice. We developed a 2-hour in-clinic simulation training to help clinics adapt provision of the new emergency contraceptive option into their unique clinic workflow, and conducted the trainings with 3 clinics, a midwifery clinic, a county health department, and a community health clinic. The first simulation scenario began with a patient actor entering the clinic, explaining she had an urgent need for emergency contraception. Then the front desk staff checked their actual clinic schedule for the day to see if they could accommodate the same-day visit. If they were able to fit in the patient, they scheduled the patient using a test EMR record. The patient then followed the typical procedures of the clinic, proceeding to the patient room, screening with the medical assistant, and counseling on emergency contraceptive methods. The scenario ended when the patient ultimately decided she would like an LNG IUD as her form of emergency contraception. For the second scenario, the patient actor arrived for a scheduled IUD insertion appointment and shared she had unprotected sex a week ago. After a negative urine pregnancy test, the provider then decided if they were comfortable placing an IUD during the visit. Through our trainings, clinic staff were able to practice implementing a new clinical recommendation and identify and problem solve potential barriers to clinic implementation. The simulation trainings created an environment where clinics could practice implementing new evidence into their clinic and problem solve potential barriers in a low stakes environment. We are now working on additional ways simulation trainings could be utilized with other changes in practice recommendations as a way to move innovations in clinical care more quickly along the translational spectrum from knowledge into action.
Built upon FPE's webinar series, we wanted to continue offering a didactic component, but also allow providers to engage with clinical experts on patient cases. So voila, Family Planning Echo began. Launching in September 2021, we've hosted a range of topics from updates in emergency contraception, how to teach adolescent health in Utah, to looking at abortion laws and regulations in restrictive states. We wrapped up our first year of Family Planning Echo on Wednesday, May 11th, but if you missed joining us for this first year, there will be more opportunities when we pick right back up with new topics and guest speakers in September.
Like proud parents, we watched all of our FPE clinics across the proverbial graduation stage this year. Our last clinic graduated from the program in March of 2020. At each graduation, we conducted one final interview with clinic staff to capture their overall experiences and impressions of the program to include in our process evaluation. We also provide each clinic with a quick data snapshot highlighting key metrics from their participation in FPE CAP. Finally, we go through patient assistance programs to help make methods more affordable. Even though FPE CAP must come to an end, we're still dedicated to helping clinics find low-cost options for their patients moving forward. FPE CAP may have graduated our final clinic out into the world, but we're not quite empty nesters yet.
In 2021, FP welcomed Planned Parenthood's Metro Clinic, Moab Regional Hospital, People's Health Clinic, Sacred Circle Healthcare, Salt Lake County Jail, Southern Utah University, Urban Indian Center of Salt Lake, and the Campus Contraceptive Initiative, all as FPE CAP affiliate sites. Each of the affiliate sites receives 1 year of programmatic support through a combination of training, technical assistance, contraceptive method provision, and service reimbursement for eligible clients, and counseling and education materials to share with patients. These individualized partnerships have allowed us to bolster contraceptive access for more Utahns, while also learning more about non-traditional contraceptive care settings and the diverse patient populations they serve. Additionally, in the past several months, we have begun working with 12 county health department locations throughout the state. We've provided training on person-centered counseling and brainstormed with health department teams how we can improve emergency contraceptive access for their communities. And we very much look forward to collaborating with them further. And a few highlights from our affiliate partnership include expanding contraceptive choice for patients receiving abortion care at Planned Parenthood Metro Clinic. Through our affiliate partnership with Metro, patients had the option to either initiate no-cost contraceptive care at the time of their abortion or later at any Planned Parenthood clinic in the state. And we base this on research that has demonstrated that many abortion patients actually do not want to initiate contraception in the abortion setting on the day of their procedure. So FP wanted to provide patients with the option to receive no-cost contraception at any of the Planned Parenthood clinics. And our programmatic data demonstrates that a significant proportion of FP eligible patients at Planned Parenthood Metro did end up utilizing a partnership to start no-cost contraception at a later date from their local Planned Parenthood clinic. Another highlight of our affiliate program was uncovering administrative barriers to emergency contraception on campus. Last year, we provided technical assistance to the Center for Student Wellness at Southern Utah University to expand student access to EC on campus. And we continue to work with the Board of Pharmacy to support understanding of how to provide that emergency contraceptive use. And then finally, we have been able to support patient choice and high quality contraceptive care in the carceral setting. The 2021 legislative session saw the passage of House Bill 102, Contraception for Inmates, which requires jails to provide continued contraception for individuals in its care. Providers and staff at the Salt Lake County Jail requested training and technical support from FPE to meet those needs, and 2 of their providers took part in our October regional training, which emphasized clinical updates on the full range of methods and patient-centered counseling. We look forward to deeper collaborations with the Salt Lake County Jail in 2022 and to learn more about the logistical and ethical challenges of delivering contraceptive care to patients with a restricted autonomy and to identifying best practices for supporting their contraceptive choice and access in this unique setting.
So now on to some policy updates. So FPE was designed as a demonstration effort to show what great family planning access across the state could and would look like. We have continued to be engaged in communications around policy at the local, regional, and state level, as well as with national partners. We've continued to participate in coalition building and education and research efforts specific to progressive pro-family policies. And we've continued to be active in providing research and coordinating provider input on maternal health and contraceptive related legislation, as well as shedding light and providing evidence-based research on the harms of anti-abortion legislation. So here are some of the efforts over the last 3+ years that FPE has been actively involved with. We have found that actionable research holds policies and policymakers accountable. These are all evidence and equity-informed policies and principles that drive systems or drives us toward and states toward creating equitable systems of care for all people. So for those of you who are along for the early days of FPE, you may remember that we had to respond to policy changes, especially as to how it related to Medicaid family planning coverage and what those
pieces of legislation and implementation looked like. So that meant that FPE covered contraceptive care for individuals with with incomes at 0 to 100% federal poverty level between February and April of 2019, then expanded to 100% to 250% from April to December, and then finally was able to cover folks, including folks from 139% to 250% federal poverty beginning in March of 2020, and have been able to continue to do that over the last 2 years. So statewide, the Medicaid enrollment rate was slower and lower than anticipated by the Medicaid office and advocates. So we definitely saw the complexities of the waivers and implementation and eligibility criteria to be barriers for your clients and clinics that were implementing the FPE cap. So despite the legislative efforts and new Medicaid expansion implementation in our state, our quarterly update calls and process evaluation interviews with clinics and FPE stakeholders identified some things that we felt were significant and are significant to share, including the burden of application to the Medicaid program, the burden of or barriers related to enrollment requirements, and lack of presumptive eligibility as barriers to Medicaid utilization, specifically as it pertains to family planning services. Monthly service delivery data and trends corroborated these anecdotes and showed that the proportion of Medicaid eligible clients seen at FPE cap clinics remained largely unchanged between the pre and post FPE cap implementation. So it should be noted, though, that relying on often missing client reported income is an unreliable metric. And so trying to make sure that we're fully encompassing these folks who continue to be in need of contraceptive services remains a priority. So we will, FPE as a group and our future endeavors will continue to be engaged in policy efforts and involvement. So we are still very much paying attention to Medicaid family planning amendments moving forward, both in this most recent legislative session, as well as the things that we anticipate for 2023 and the conversations that are happening during the interim. And really using the data and experiences from you all and from FP CAP to inform those pieces of communication and the evidence that we're providing to stakeholders. So, really highlighting the importance of presumptive eligibility, removing of cost sharing as it relates to contraceptive services, and the importance of extended supply. We're also bringing to light the important areas of 12-month postpartum care and folks that would be eligible for that extended postpartum coverage, and expanding pregnancy eligibility to really make sure that folks who want to become pregnant and want to in reproductive justice values aligned manner, we're able to support those policies with good data as well as strengthening Title X, having centralized resources, as well as decentralized direct care. So there's some exciting things in our future.
Oops. And some of our aha moments.
While COVID switched communications online, FPE looked for ways to continue to safely meet with clinics on their home turf. Through simulation visits, dropping off FPE supplies, and offering in-person trainings, we were able to continue to build relationships in the way that perhaps is only possible face-to-face. Traveling to clinics gave us the opportunity to learn how individual clinics do care and problem solve barriers that were specific to their location and their communities. We saw that it was much more effective than centralized trainings. We also learned that when you do clinic level initiatives, taking a full staff approach where MAs and providers had buy-in and a central role, it had a much more transformative effect.
Sure, it isn't quantum physics. Nonetheless, ensuring that we had standardized data from all of our intervention sites to compare for the quantitative portion of our evaluation was a challenge. Our first challenge was making sure that the data we collected would actually allow us to evaluate our primary outcome. It took us a few months to determine exactly which variables we needed clinics to report on. As soon as we had our variable list defined, we encountered our next and arguably biggest challenge with data collection. We found a ton of variability in what information clinics collected from their patients, in the completeness of that information, and in how this information was stored in each clinic's electronic health record system. It was incumbent upon us to learn what queries would pull the data that we needed from each clinic's EHR, and to work closely with clinic staff to tackle what was often a daunting task of setting up these ongoing reports. After 2 years, updating our master data set of clinic service delivery data has become something of a rote process, but this is only because of the months and months of data wrangling and analytic gymnastics of Olympic proportions.
We also found out that scaling contraception mirrors more of a patchwork quilt versus a monolith. From our billing and reimbursement protocols to our media campaigns, our project was totally customized, not cookie cutter. While it definitely would have been an easier lift to employ a blanket media campaign, it was much more effective to work with each site to determine what their needs were. However, we still saw sustainable impact. FPE created an environment where providers could see what care is like when cost is removed. They weren't okay going back to care with big choice barriers and worked to establish different ways to provide no or low cost family planning care to their clients through COVID relief funds.
We also found out that keeping our values while we're putting this program to action is hard too. So we established Family Planning Elevated to be a program that really walked the talk and incorporated the current best practices and principles of the contraceptive field into the program. And among these was that we weren't here to reduce unintended pregnancy rates or to increase use of IUDs and implants, but really to expand access to high quality person-centered care, and specifically care that includes support for method switching and discontinuation. And we did do that. But just as new parents have the best laid plans, like no screen time, we found that there were key areas where our values collided with the programmatic realities that called for us to get more creative and committed than we initially anticipated. So one example of this is method equity. We have been committed to expanding options for clients, including to methods that get a little side eye due to their typical use effectiveness. And as method neutral as we consider ourselves, there were times during the program when the cost of stocking these methods and the effort of training on these methods like diaphragms and cervical caps did feel burdensome. And yet, if you take a step back, these investments are considered standard for methods like IUDs and implants. So we have stayed the course advocating for a wide range of methods, and we did see an uptick, both in provider attitude, in counseling skills, and ultimately in utilization, but it took determination. Another example is removals. So this is an area where putting our values into action has been challenging, and ensuring patients continued access to no cost or low cost removals after clinic participation in FPE has wound down. So placing an IUD or an implant in our minds represents only half of the clinical responsibility to a client. So how do we ensure the other half? In our experience over the last year, revising clinic contracts, ironing out reimbursement challenges, clarifying eligibility, making this free removals offer a reality has been its own mini initiative, and utilization has really been a lot lower than we expected. It hasn't changed our commitment. It has just made us curious about other ways we can continue to ensure timely removals, and that includes additional research into supporting IUD self-removal. So we're keeping at it.
Our team also worked to balance the needs of implementation and evaluation. FPE is both an implementation project and a research project, and our team is committed to increasing access to high-quality contraceptive services and to researching the need for and impact of our initiative. And while much of the time the interests of implementation and research are well aligned, there have been times when our team has needed to make decisions between what is best for the clinics and patients we are working with right now and what is best for the future clinic and patients that our research will help us reach. And I know this is talking in abstraction, so let me give an example. As FPE CAP clinics were preparing to graduate from their 2 years of participation in FPE CAP, most of the clinics had some donated IUDs and implants remaining. From the implementation goal of increasing access to high quality contraceptive services, it made the most sense to leave the remaining devices with each clinic. From the evaluation side, we knew if we left clinics with a sizable stock of devices after their time in FPE was over, we would be confounding our research findings, letting the impact of donated devices linger in the service delivery data after the rest of the program had ended. Ultimately, we decided to let each organization keep a small number of the remaining devices, and we are carefully tracking each remaining device so we can properly account for it in our final data analysis.
So after 2 years of regular meetings with our Reproductive Justice Community Advisory Board, and after having to shift to online meetings, the board decided that this was no longer the best approach and that scheduled meetings were no longer mutually beneficial to the project or to the community. So in response, the FPE program community engagement became much more community driven and more project based. And those are projects that have originated within the community. So it's been an exciting growth, but we learned a lot along the way. So no doubt that aligning academic, healthcare, and community values takes humility, learning, and listening. So I want to share some of the things that we highlighted here. Embracing community as equal partners in this work is essential. Making sure to prioritize relationship building before task is fundamental. Community stakeholders offer researchers in academic settings valuable expertise as they share their time, skills, talents, experiences, and perspectives, and that has continued to be true, and we are forever grateful. And equity-informed research requires curiosity and humility and a long-term commitment to stay in these collaborations and in community, and so that is one of the things that we are committed to. Centering priorities of community organizers has led us to create community partner affiliates, and those include a Birth Justice Fund in partnership with the Birth Workers of Color Collective here in Utah, as well as the Utah Abortion Fund as a community affiliate to provide mutual aid and direct distribution of emergency contraception, condoms, and pregnancy tests to folks in their network.
Although we are sad to reach the end of FPE CAP, we still have been incredibly busy strategizing our next steps forward and have a vast array of work that will continue to support and expand care in our state. We're excited to share a preview of some of our upcoming projects in focus. In 2021, the Family Planning Division at the University of Utah was granted designation as a center, and the Ascent Center for Sexual and Reproductive Health Research, Education, and Policy was born. This designation allows for greater opportunity for collaboration, funding, and support of sexual and reproductive health. As FPE CAP comes to a close, we hope to move forward in the Ascent Center with new and additional trainings and partnership opportunities in the state of Utah to ensure the best reproductive and sexual health, contraceptive access, and abortion care possible in our state. As you are likely aware, abortion as healthcare is currently in a precarious position due to national and state legislation. As the Ascent Center, we are committed to supporting and providing the best possible care and accessibility to the full range of sexual and reproductive healthcare, including abortion, and will work to provide communications to providers and patients and include knowledge and resources in our communications. We hope you will view the center as a centralized and safe resource to ask questions and seek support around abortion knowledge and access in our state.
Pharmacy access laws authorize pharmacists to prescribe and dispense contraception, which can make contraceptive care more accessible and affordable by eliminating need for a separate visit to a healthcare provider. Pharmacist education and collaborative practice agreements that include referral networks are key implementation strategies to ensure that this policy extends beyond theoretical access.
So collaborative practice agreements, or CPAs, are an approach that has worked well to ensure that pharmacists are integrated more fully as part of a patient care team. So this is an area that FP is looking at. These formal agreements can be expanded to different aspects of an individual's healthcare team as well. Typically, the licensed provider engages as needed in clinical care, makes diagnosis, supervises patient care, refers patients to a pharmacist or community health worker or other partner under a protocol that allows for the full care team to perform specific patient care functions. So we're excited to engage creatively in this space, acknowledging that much of health happens outside of the clinic, and that FPE and the Ascent Center can continue to support these efforts. Again, with the Regional Family Planning and Abortion Network, we hope to build on the strong relationships with clinical and community partners, and continue to strengthen the network that FPE has worked with. We're mapping expertise and referral pathways that exist, as well as building new pathways where the need has been identified by you all and the folks living and working in these regions across the state. So thank you to all of you who have been instrumental in being a node in this network already, and helping identify other family planning champions to be a part of this network in the future. So stay tuned as new funding and material resources and opportunities become available. So we will continue to share those with our existing and new partners.
And finally, our network of providers and clinic staff, many of whom are joining us here today, throughout the state can count on us to show up with sharpened pencils, a box of bagels, or other kind of breakfast pastry, and the latest information on a range of reproductive health topics. This fall, we'll be hosting another advanced contraceptive skills training. This one will be a little bit larger than our last, and this is for trained providers eager to hone their clinical and mentorship skills further in quality family planning. As Erica mentioned, our Project Echo series will be on hiatus over the summer, and we bid farewell to our graduating complex family planning fellow, Dr. Amy Clement, who spearheaded this series with us last fall, and welcome our second-year fellow, Dr. Misha Pangasa, to take over the Echo helm. We're eager for more clinical cases from providers, so please don't be shy, submit yours and tune in this fall. We will continue to create resources in response to your needs, from clinical resources for providers to administrative job aids to patient-facing educational materials. And this is especially true as we head into a new landscape for abortion access this spring. We know it will be important to understand legal parameters and get connected to local resources for supporting clients for the full range of reproductive health services. And of course, our standard trainings on contraceptive methods, counseling, and simulation, and our bespoke trainings on really anything will continue to be available to our extended family of clinics throughout Utah. So tell us what you need and we will be there. And a shout out to our partners and our donors and our friends and our families, everybody who was able to make this project possible over the last 3 years. And now we can turn the time over for questions. You can either type them into the chat, use the raise your hand feature, or just come off of mute and ask us. We are all here in the room, so if there's something you'd like to direct to a specific person here on FP, just let us know. And if it's the recording that's making you shy, I'll pause the recording right now.